with Professor Dr. Gausal Khan from the Department of Clinical Nutrition, King Faisal University. He will speak about the insulin resistance type 2 diabetes vaccine.
I hope this is the kind of patent I received, and as far in my knowledge, only one patent been approved. It is from the one of the group of Japan, and it is in the phase 3 clinical trial. It is the GLP-1 vaccine. It is totally different than this one. Here is the details of the approval. The patent I received, and I am only the sole author or sole inventor in this patent. The claim in this patent, I made it a composition of treating or preventing the insulin resistance and comprising a peptide of sequence 1. Actually, one sequence have been identified. This the sequence from the part of the VWF C-terminal end, and a pharmacological acceptable carrier or adjuvant method for inhibiting or preventing insulin resistance, comprising the administrating a therapeutic effect of amount of composition of this peptide to a subject of the need thereof, and also claim is B cell secretion of the polyclonal antibodies for neutralizing insulin receptor binding portion of the VWF protein, and also a method of increasing nitric acid production, and therapeutically effective amount of the composition of claim 1 to be subject or in need in thereof, and also the comprising of a peptide, the sequence I made it, and a pharmaceutical acceptor carrier of the adjuvant, and nitric acid production in a subject comprising the administrating a therapeutic effective amount of the of a composition comprising a peptide sequence, and to a subject in need thereof. Before going to talk about the diabetic vaccine, I would like to explain a little bit, remember about the complication of diabetes. Diabetes is one of the major complications in worldwide, and it is growing up day by day. And if you look at these numbers, it is really astonishing and concerning, and especially the type 2 diabetes, and it is the insulin is there, but insulin failed to work. And the trend, and the trend, or you can say the prevalence and prediction of is in the million, and it is going up, in a speedy fashion, and hopefully in 2045, it is about to 783 million people is going to affect. So it's kind of very concerning disease, and I'm working this one more than 15 years. There is a theory. Most of the disease are being originated from the inflammation, and inflammation is the key of the insulin resistance. If you look at this cartoon or the figure, if you look at here, if you see there is inflammation leading to due to obesity and diabetes and infection related injury, whatever you can say, everything is related to one link to another, and the ultimately the insulin resistance is the initial event of the setting off of diabetes type 2. And that is the insulin resistance leading to systemic inflammation, or systemic inflammations leading to insulin resistance. That has been a lot of debate, and leading to ultimately is the inflammation, and leading to cardiovascular disease, diabetes, kidney damage, diabetes retinopathy, and so many things are going to happen. Now I am going to back down to how I came to this point of the vaccine, as I work in the stress and hypoxia in my previous lab, where I was a senior scientist, and we are looking at hypoxic stress, hypoxia, how hypoxia can trigger the endothelial dysfunction. Very interestingly, what we found that hypoxia leading to endothelial dysfunction and leading to thrombosis, even heart failure. But the very interesting things we found, there is an increase in the von Willebrand factor. It is known as the factor 8 carrier molecule. But same time, we found that there is an inhibition of nitric oxide. Then that gives me a kind of thinking. So there is any kind of relationship of the VWF increase and decrease of nitric oxide? So what we found that if you look at the blood in down, there is an increase of VWF multimer, when you expose the animal with the hypoxia. And at the same time, if you look at the nitric oxide production, in the animal, there is a significant decrease, and there is an inverse. So it looks like there is some kind of inhibition is going on. So changing these things, and it has been already noticed, and it has been identified in high altitude patient or individuals. The people are in the high altitude, going to be in high altitude, and they have insulin resistance. And they have the information diabetes in human. So that gives us thinking there is a kind of relationship between the two. Looking of these things, here is one of the study is conducted. This is farming hospital studies in 2008. This is the study is giving me a thinking. There is a relationship between VW and type 2 diabetes. And they studied in 379 patients in Europe. And that gives a little bit clue. Yes, there is a relationship in a real human setting. And whatever we are finding in the hypoxic experiment. And the thing is here, if you look at this, this is the same paper, and here is the details. And they first time told about the elevated level of VWF are associated with increased risk of cardiovascular disease in community-based sample. And type 2 diabetes or insulin resistance and elevated VWF are they have a relationship and potent independent risk factor in the type 2 diabetes resistance, which support a role in pathogenesis of atherosclerosis as well as CVD. Next, in the patient, present finding be confirmed in the population ED homeostatic dysfunction and also insulin resistance, so develop in type 2 diabetes and insulin resistance. So this is the community-based studies and give us the real thinking. Yes, something is going on, and there is a relationship between VWF, but how? What is the mechanism? And we know that stress leading to endothelial dysfunction, and there is a genesis of nitric oxide, and nitric decreases. So reduced bioavailability of nitric oxide is thought one of the major central factors in the progression to resistance, because nitric oxide is the second messenger within discover, and it is the key activation of the GLUT4. So insulin generally binds with the insulin receptor. It is actually the nitric oxide synthase. So once it's bind, nitric is produced, and nitric oxide actually translocate the GLUT4 from cytoplasm to membrane, and is open the channel so glucose can enter. And so there could be a relationship in stress. So that gives us the whole idea. Now, in the animal setting, what we found that there is an increase of a lot of molecules like endothelial dysfunction and also the HMGB1 and VWF. And there's some stress protein. Also, this is the ELISA we have done, and it's all been published. So here there's a system. There's no time-dependent increase of the VWF. If you look at the insulin resistance parameter, GTT, ITT, insulin resistance tolerance, and the home IR. Home IR is the main determinant of the whether the animal or the human are insulin resistant or not. If you look at here, it's a time dependently it is going on. So home IR is the see. If you look at here, it's going on. So that means hypoxia-induced insulin resistance. Whatever we already there is a lot of information been there in the hypoxic individual. So we are also looking at the same kind of human the animal setting. Now, is there any kind of relationship in human and inhibition of nitric oxide due to the VWF? So here, the experiment what we did, we took the we exposed the animal, and we look at the insulin, nitric oxide production, and also we take the same blood and we inject it in the normal, and also we use the one of the recombinant protein of the VWF. The very interesting, I can explain, tell you, it is the luck of mind which I discovered, because the VWF is a big molecule, is a 500 kilodalton, it's a multimer. Lot of the, I will tell you later part of my talk, lot of the structure is not been identified yet. We don't know what is the sequence, but it is my luck. I've been purchase a clone, which clone is exactly doing the same whatever the VWF is doing in the system. So this gave me my chance of luck to discover this and come to the vaccine. And if you look at here, if you inhibit the VWF, and depleted plasma is restored. And the same thing, we use this recombinant or human VWF, we do the same kind of innovation, and we should chase the interesting part. I can say that the maximum inhibition is the 125 picomole of VWF is exactly the physiological amount. So we chase the two strategy to look at whether the environment nitric acid is there. So there is kind of patch is available, which has been discovered by us, and also use the nitric acid inhibitor. It's called the L-name. And patch is available to the market in Johnson & Johnson. If you put in the skin, it is for nitric oxide, and blood sugar is going down. So we use this two strategy. We use the patch and put in the animal, and the same experiment we did it, and you can see, and once we put the patch, it's reverse. The insulin, HOMA-IR, ITT, GTT, everything reverse. That means if we can somehow induce the nitric oxide, so we will ameliorate the insulin resistance. So here we use again the insulin resistance parameter. We use here the antibody of the VWF. We generated, and this antibody is two different types. The peptide, the protein fragment, we get it. We use this antibody, make the antibody, and is the vaccine, whatever, does the same thing. So we use here, and we inject it. If you look at inhibit, the antibody in the yellow is inhibit as a normal, and the same thing, HOMA, and if you use the L-name is decrease. We also studied the C14 glucose uptake. That is the key. Glucose will uptake in the red blood cells, so it's the C14 level glucose, and we did, and we proved it. Yes, it is having a role in the glucose uptake. So here is the things the other way around. If you look at these, what kind of inhibition they are binding this with the insulin receptor. So if you the higher dose of insulin in the same model of VWF, 100 to 25, the physiological amount is totally reversed. What you find in the patient, if patient having insulin resistance, 1 unit, sometimes it's going to not work, then 2 unit, 3 unit, 4 unit, and goes on. And this is the same way we showed in animal model. Now we are counting whether this VWF is binding with the VWF, binding with the nitric oxide synthase. It is, I called it is the insulin receptor itself. Yes, we proved by the far western blotting as well as co-inverse specification, both proved it's binding. And this is the state of art. We did the surface plasma resonance spectroscopy, and we proved, yes, VW binds to nitric oxide, and we found the KD and KM, all these things. And if you look at the KD and KM, and next stage we have to do the kinetic analysis. See, this is the kinetic analysis of the IC50, and IC50 we determined the inhibitory constant, and exactly the same thing, whatever we found the Ki at 250, and exactly the same in the physiological dose. that give us really, really strength. Yes, whatever we are founding in the enzymatic system on the test tube is exactly following the physiological doses. So we found here that it is a competitive inhibition, it is a non-competitive, uncompetitive, and we found the IC50. Now, whether this thing happening in the real human sample or not. So we took this diabetic type 2 diabetes and we look at try to find out the correlation with the human sample. You know, all the study we have done in the animal. So now we took the blood and measured the PWF. PWF is remained in the multimeric form. You know, that is very important. And monomer is never going to active. Normally it is in the monomer, and when it is been stacking one by one like coin, so it is a multi-one next to you have it. And if you look at the HOMA-IR, so it has a kind of correlation, yes. So PWF for HOMA-IR means it is having correlation in patient sample. Here is a structure I told you earlier. PWF is big molecule. You can't see a lot of the structure not being determined. And here I want to say the Adams 13. It is one of the molecule which click the PWF monomeric to multimer to monomer. So it is inactive. See how the monomer is formed. Multimer become monomer. Adams 50 monomer doesn't have any role. If so many monomers normally is present, it doesn't going to work anything. It should be multimer. That means the Adams 13 should be inhibited. And that is the human PWF, what we have, that's the sequence made it here. See, we prove it is active form. And this is the structure. When we do the structure modeling and with how the PWF and the insulin receptor working, the C-terminal part of the 199 amino acid sequence exactly binds to the insulin receptors. So now, this work I've done in 2013, and that time there is no structure been defined or crystal structure not been identified even by scientific community. So I never had a chance. How could I, modulate? But luckily in 2013, this paper came out from one of the Australian group, the first time in the world after the 100 years before the insulin was discovered. And they found the insulin receptor crystal structure. So this is another luck of mine. I took this opportunity and modeled. See, and exactly when I took their structure, I modeled my structure and the loop 2 exactly fitting with the insulin receptors. And the RMS is 0.5. So I told you, yes, this is the done. So earlier I had already developed the antibody, and I already, this sequence, I already injected, and I found the result, yes, it's inhibiting. So now we have to do some kind of efficacy, toxicity, and synthesis studies, and we use the animal model of same. So initially, the PWF having a role in the coagulation. So we want to know whether there is any kind of changes is going on in the bleeding time and clotting time. So we did the studies, and efficacy, ELISA, GTT, ITT, HOMA-IR, and toxicity, proliferation assay, and LE-spot. These are kind of little preclinical studies we have done. And so here, see, the toxicity, there is no toxicity of this whole thing, antibodies. See here, there is nothing is changing in our animal model. We have done like 10 animal samples, and we found that there is no toxicity of the clotting side, whatever the major thing, and CT and BT means bleeding time. And this is the model. Actually, there's a normal proposal when the VW is there. VW is a normal situation multimer. It's never having any role or not can even bind with the insulin receptor. So insulin can bind, and it's nitric acid produce and glucose is going on. But only the problem once it is in stress or even the hypoxia. So during the stress and hypoxia, so PWF producing a lot, and PWF become the monomer, not a multimer, ultra large monomer. So here, see, all the monomer is binding with the insulin receptor, what I proved. Now the whole question is how we could This monomers need to neutralized. So we use the vaccine, the sequence I have it, which I got it patented. That vaccine, that patent I injected with the my adjuvant, and we got to develop a vaccine that the antibody. Actually, the vaccine is an antibody. That antibody binding, neutralizing the VWF, and it is reversing the nitric cell production. That is the whole thing. What I proved, and I gave it to the USPTO, and they satisfied, and they awarded the patent. And this is the whole thing. Right now, my plan is next is third party preclinical trial, because most of the time my preclinical trial is no one going to believe, and no one will be funding me if third party is not going to validate it. And it is because the clinical trial is millions of dollars, and someone need to any company or investor would come there. So my plan is next time trying to doing any third party clinical trial and everything. So I am going on and talking to some companies for this technology transfer. So I would like to thank the major of the work, and the whole thing is